I think
47, yes.
Yes. And I'm very happy as President of IAP Kerala, I'm very happy to have this program with pediatric Ispagan, and when Dr. Pramod Warrior called me that Ispagan is interested to have a program in association with IAP Kerala during the second week of December, I was really happy that, and I thought we will start our activities. Actually, this is the first program IAP Kerala as a state level organizing this year as the first academic program, and I'm very happy to Dr. John Mathai for opting to have their first meeting in association with IAP Kerala. And you have selected a very good, very relevant topics with appropriate faculty, and I feel this will be a good academic feast for whoever is, for the all practitioners as well as postgraduates and all of those who are interested in pediatric gastroenterology. And I'm very happy to welcome my teacher and friend and mentor or whatever. I don't know what are the adjectives I have to use, Dr. Riaz, because he was one of the persons who dragged me to pediatrics when I was undecisive what specialty I should opt for. So I am very happy to see Dr. Riaz as the first speaker or the first CME, which Kerala IAP starting when I am the president of IAP Kerala. So welcome Dr. Riaz to the CME, and I hand over to Dr. John Mathai to continue the proceedings. Thank you.
Thank you, Dr. Jayaraman. On behalf of the Indian Society of Pediatric Gastroenterology, Hepatology and Nutrition, ISPAGAN in short, I want to welcome all the delegates who have logged in. It's your participation and your involvement that will mark the success of this program and will make the organizers and the faculty happy. So please take part by putting your questions in the chat box. We have almost 30 minutes of time allotted for questions. And please make use of that so that we can answer as many questions as is possible, because each of these 4 topics are vast. And we're going to be only covering some aspects that are relevant to practicing pediatricians. We can't cover everything. So that's welcome to all of you. And I want to thank Dr. Jayaraman and Dr. Johnny Sebastian for giving us the honor to partner you for your first program under your guidance of IAP Kerala. Also want to thank Pramod, my dear friend and old colleague, who facilitated this, who was the one who coordinated this program. Thank you, Pramod. We are very proud of you and all your academic activities that I've been following for the last few years. If you had been so very academic when you are a student, you probably have won the university gold medal, I think. A welcome also to the other faculty, to the others who have joined on stage with us, Jaya and a few others who have joined in. This is a series which is being planned along with Foods India, and this is the first of that. And I want to thank Foods India for coming forward and being our academic program partner for this series. I don't think any of the faculty need to be introduced. Riaz, I think, it's like introducing an elder brother to all of you. So he doesn't need any introduction. And Riaz is, a typical pediatric gastroenterology faculty, very approachable, very knowledgeable, and very easygoing. I think most of our faculty at a national level for pediatric gastro are like Riaz. So he's a typical pediatric gastro person. And I hope you will get to meet more people among our faculty, and you will realize there are more Riazes around. Dr. Malathi again needs really no introduction. She has been in this field for almost many decades now, and has been a mentor, guide, and an inspiration to a lot of people, youngsters in pediatrics. We also have Sumathi with us. She is the generation next pediatric gastroenterologist. She's associate professor at Stanley Medical College, and she is the South Zone coordinator for all ISPAGAN activities. And I want to welcome both Dr. Malathi and Sumathi to this program. And we hope all of us together can make this program academic. Therefore, it's useful to everybody. I would also request all the delegates to please give your feedback to the company reps or through the chat box so that we can improve. It's always a learning experience for us on what you want. Because this is a series, I'm very keen that we get your feedback so that subsequent programs can be tailored to the interests of the delegates. With this introduction, let me invite Dr. Riaz to give his talk on abdominal pain in children. Dr. Riaz, for you.
Is my slides? Can you see my slide? Hello? John, can you see my slides?
Yes, I can see. Yes.
Yes,
We can see. We can see.
You can start.
Yes, sir.
So, good evening, everybody. First of all, I would like to thank Dr. T.P. Jairam, my old friend and one of the best pediatric colleagues, and the dynamic president of IIT Kerala, and Dr. Johnny Sebastian, and also my pediatric gastro colleagues, my friends, Dr. John, Dr. Sumathi, and Dr. Bandi, for giving me a privilege to be a part of this fascinating seminar program. Now, recurrent abdominal pain is, as you know, is one of the most common problems encountered in the pediatric age group. Almost 15% of school-going children have abdominal pain. In fact, almost 5% of all pediatric consultations and almost 30%, 1/3 of our pediatric gastroenterology consultations for this vaccine problem is a very important cause of school absenteeism, and this drives to depression not only the child but also his parents as well. So I shall discuss the classification, briefly the pathophysiology, evaluation, some of the red flags, and very briefly about the management. And now it's indeed fortunate that in more than 85% of children with chronic abdominal pain, they do not have an underlying organic pathology. And organic pathology is seen only in about 10 to 15%. The dictum old is gold is always true, and we have the beautiful classification or criteria put forth by none other than John Apley way back in 1958. Most of his criteria hold true even now. He said that if there are more than 3 episodes of significant abdominal pain in 3 months, and the pain episodes may last for more than 3 minutes with a clear symptom-free interval between the episodes, and the classic age group is 5 to 15 years. Now, there are several other classifications, NASPGHAN classification, Rome classification, and these are going to confuse the general pediatrician. So I will be discussing mainly the NASPGHAN classification, which I feel is a very simple one. So they discuss what is known as chronic abdominal pain, in the child has got constant or intermittent pain that may be either functional or organic. We leave behind the organic and concentrate only the functional abdominal pain. Functional abdominal pain means that the child doesn't have any serious underlying pathology to account for the pain, and functional abdominal pain can be subsequently divided into 4 types. The dyspeptic type of abdominal pain, the IBS or irritable bowel syndrome, the abdominal migraine, and the fourth one is a group in which the patient has got a chronic abdominal pain but does not have features of dyspepsia, IBS, or abdominal migraine. This is a very simple classification for young pediatricians. You know that there is a very delicate balance, very interesting balance between the brain, which has got 1 billion neurons, and the gut, which has got 1 million neurons in the enteric nervous system. So whenever there is some change occurring in the gut, it may be reflected, it may affect the brain also. That's the one reason why when there is an increased peritonic contraction, that may be conceived as pain. Now, the Rome 4 criteria, just briefly mention the Rome 4 criteria. The Rome group is actually a group of very active researchers. They're doing intense research in functional gastrointestinal disorders. And they've recently changed the name of functional gastrointestinal disorder from, that is FGID, to gut-brain interaction disorder, mainly because of the huge interaction between the gut and the brain. So these are nowadays known as the gut-brain interaction disorders, or the GBIDs. Now, one thing I would like to mention about the Rome for Titan is that many children are brought to us nowadays with nausea, especially in the morning. And according to Rome for Titan, this is almost always a manifestation of an anxiety disorder. The reason may be that their level of cortisol secretion is always increased in the morning, especially around 8 a.m. And cortisol may also be released in response to stress, and it may be a mediator of anxiety also. So this is one reason we get a lot of children nowadays with nausea without any other features. We can really console and reassure the parents that this is not a serious problem. Now, there have been a lot of articles on the prevalence of nausea in children, and this article came in the Journal of Pediatrics in 2016. You can see that the p-value is always very significant. Now, how do you approach a child with chronic abdominal pain? I'm actually very fond of this particular slide because the first is history. And I've written history 3 times. That doesn't mean that the student should write history 3 times in the answer paper. But just to underscore the importance of taking a proper history, because if you do not take a proper history, you will miss the diagnosis. Then you examine the child and do the relevant investigation. So definitely, pediatrician should be like Sherlock Holmes. Not only in the evaluation of chronic abdominal pain, any problem in pediatrics, we should be like Sherlock Holmes. So in the evaluation of a child with abdominal pain, the pediatrician should be very careful. There should not be anxious over investigation, nor should there be helpless and under investigation. Both are detrimental. So it's a duty of the pediatrician to strike a balance. Do not over investigate or under investigate. You have to strike a balance. The history taking, you'll be surprised to know that in Kerala, some of your colleagues see about 300 children daily. It's a whopping number of 300 children daily they are consulting, and they usually do not miss any clinical findings because they're all very good clinicians. But if you want to evaluate a child with chronic abdominal pain, you will have to spend at least 45 to 60 minutes with the child according to the Western criteria. I personally feel that at least 30 minutes should be spent with the child, and this will reassure the parent and child. You have to anchor for a history of celiac disease, inflammatory bowel disease, IBS, peptic ulcer disease. The food habit of the child is the child taking a lot of chewing gums, candies, which contain sorbitol and which can aggravate abdominal pain. Has the child been abused physically or sexually? Either family history of migraine. So history taking is very important in children with chronic abdominal pain. So again, coming back to John Apley, he had put forth a very significant note. He said that the further the pain is away from the umbilicus, the more likely it's an organic person. It means that a child with chronic abdominal pain, if it's got pain in the periumbilical area, it's likely to be more likely to be functional. So if a child with chronic abdominal pain has got periumbilical pain, we know that 95% may be functional, but again remember the organic condition may be seen only in less than 5%. And these are some other conditions which may present with periumbilical pain like abdominal epilepsy, venous colic, abdominal migraine, etc. Now, what is dyspepsia? Dyspepsia is usually a term used by not by pediatricians, but mainly by gastroenterologists. The literal meaning of the word dyspepsia is not just an upset stomach. So the child has got upper GI symptoms, anorexia, belching, heartburn. It may be due to delayed gastric emptying because if you do an endoscopy, there is no ulcer. So it's also known as non-ulcer dyspepsia. So when a child with chronic abdominal pain has got dyspepsia, you should be careful because 20 to 25% may be having underlying serious organic pathology, like some other mentioned here. Well, if the child has got altered bowel habits, what are the possibilities? 75% is got to be a function, that is irritable bowel syndrome. But an organic cause may be found in almost 25%. So you should be again careful because Crohn's disease, celiac, tuberculosis, etc. can present with altered bowel habits. Now coming to IBS, it's a pan-irritant. So who are the people who are irritated in irritable bowel syndrome? Naturally, the child is irritated because he doesn't go to the toilet so frequently. The parents will definitely be irritated because the child is always complaining of pain. What about the pediatrician? The pediatricians too will be irritated. Why? Because the child is brought back to the pediatrician saying that, doctor, your treatment is not at all good. There's no relief. So it irritates the patient, the parents, as well as the pediatricians. So what is the ABC of IBS? In essence, IBS, irritable bowel syndrome, is abdominal pain, bloating, and change in the bowel habit. These 3 features will be present in a child with irritable bowel syndrome. What is FODMAP? I hope you are familiar with FODMAP. This is an acronym. It stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. These are actually Carbohydrates, short chain carbohydrates, which are not absorbed well. So these can result in abdominal pain and bloating. Remember that FODMAPs are commonly seen in natural occurring foods as well as in some additives added to food. So if a child with IBS is taking a lot of high FODMAP food, his symptoms may be aggravated. The classic example of a high FODMAP is wheat and wheat-based food, followed by honey, ice cream. We're all fond of honey, ice cream, apples, etc. Chewing gum, high FODMAP. So we should try to avoid high FODMAPs and should be replaced with low FODMAP foods. Rice, which is we are very fond of, especially Kerala people are very fond of. South Indians are very fond of rice, banana, orange, all these are low FODMAP foods. Now, what we should remember is that the pain that the child is complaining is actually real. The child is not faking. When she thinks that the child thinks of a very tough-looking teacher like this with her cane, naturally the contraction of the gut will be increased, and that is responsible for pain. So, but we tend to call the parents as well as sometimes the doctors say that the child is pretending. In fact, there is even a term called pretendicitis. Remember that the child is not faking; he's really suffering because the pain is real. So, what is the role of stress? There is a very famous statement by Grossman. He said that the more sophisticated countries, the more belly aches will it have, and little belly aches develop into big belly aches. For example, a toddler with abdominal pain tends to become a teenager with abdominal pain, and finally also an adult with abdominal pain. That's the role of stress. Now we should remember that constipation is a very important underlying cause of chronic abdominal pain, and you should also remember that no parent will volunteer the information of constipation unless they are specifically asked about it. The child may say that he's got a pain in the anal area when he's defecating, that is dyschezia. Or if you again ask him, you may say that he's passing motion daily, stool daily, but he has to push very hard to have a motion. He's actually constipated, and that may be responsible for his abdominal pain. So that has to be tackled. Eat cricket, sleep cricket, drink only Coca-Cola. This is a very popular ad in the Prudential Cup tournament a few decades ago. I'm sure people like John and Malathi will be remember this slogan. And I'm sure you know that some of our cricketers that take the mysterious illness and they're forced to skip tournament. This may be because of the IBS they have developed due to the constant thunder that's so regularly tasting. Now, this is Mark Taylor, one of the wonderful captains of Australia. But of late, towards the fag end of his career, his form as offline was almost dropped from the team. Then you can always see Mark Taylor standing in the sleeves with his hands on his hip. You can never see him a minute without chewing gum. It's always in the habit of taking chewing gum. Here you can see that he's about to catch Sachin Tendulkar of Australian-born. Suddenly he got the call of nature and spilled the catch. So that is the chewing gum diet type of important cause of IBS. I'm sure that this should be common in our cricketers. What is abdominal migraine? This is a condition characterized by approximate severe midline or periumbilical pain with other features of migraine. So it's very important to avoid the triggers of migraine. I'm sure you know the popular or the famous 5 C's of migraine. Now, abdominal migraine is commonly mistaken for the epilepsy also. I'm not going to discuss this. I suppose we can discuss this particular slide during our question and answer session if there is time. Similarly, H. pylori also, I'm not going to discuss. This is a big topic. We could discuss during our question and answer session if somebody wants to know about it. Now, what are the red flags for organic disease? Red flags may be symptoms as well as signs. So when you take history, make sure all these symptoms, you ask for the symptoms. Age is very important. Family history, IBD, pain away from the umbilicus, nocturnal pain, etc., etc. Child with severe anemia, hernia, arthritis, delayed puberty, organomegaly. These are some of the symptoms, red flag symptoms, and red flag signs. Then what are the green flags? Green flags are for functional disorders. Suppose the mother is saying, the child has got multiple symptoms. He's got pain in the tummy, pain in the head, headache, pain in the limbs, pain all over. This may be a functional problem. Or the mother is saying, doctor, nothing seems to be working for my child. And the child is saying that nobody is believing her. And the mother is again complaining that the side effects with every one of your medication. These are like our family history of IBS and migraine. So these are some of the green flags which indicate that probably this child is having a functional problem. Now let's see some case scenarios. This 4-year-old child was referred to me. His father was about to return to Gulf in a couple of days. This 4-year-old child was having abdominal pain for the last few months. Okay, Any red flag sign? Can you see the red flag sign? You can see that he's extremely emaciated. His hemoglobin was 5 gram%. You can see the abdominal distended. There is a vague lump, and the CT was suggested a huge retroperitoneal tumor. So his was an organic problem. Let's see another thing. This is a teenager with dyspepsia of more than 1 year duration. It all started 1 year back when his father died from Gulf, following a massive upper GI pain. And the son was so much attached to the father that everyone thought that the poor chap was having functional pain. He had severe pain, he had nocturnal pain, and in fact, he had lost 8 kg in the last 1 year. The basic workup was normal, USG was normal, he was treated symptomatically without any relief. His stool occulbed was positive. Is there any red flag? Yes, there are lots of red flags in this child, and the scope showed a duodenal ulcer and this H. pylori was positive, and he became all right with treatment. When a teenage girl is brought in with dyspepsia, you should be very careful, especially so in the Western countries, because this could be pregnancy also. This may happen even in Kerala now. Now, a child comes to you with abdominal pain. Clinical evaluation is extremely important. Can you see these black spots on the lips? And if the endoscopy shows the polyps, what is the diagnosis? This is actually Peutz-Jeghers. And this is a rare case, but I can to look for it. Pediatrician should be aware of this condition. Or a child with abdominal pain, is emaciated, is not growing well, is the stool occulbed is positive, is got abscess, scleritis, and clubbing, severe pain. Or the diagnosis, this is suggestive cholestasis. Or this was another child with recurrent abdominal pain. His hemoglobin was 7 gram%. His BP was 140 or 110. And this is a clue for the diagnosis. You can see his peripheral smear. So this is oral cavity and the peripheral smear. For the diagnosis, I will give you a better clue. And who is this beautiful lady? In fact, she is one of the most beautiful heroines of Hollywood, Elizabeth Taylor. Okay? And what is Elizabeth Taylor's favorite hobby? That is actually getting married. And this was her ex-6th or 7th husband. If you know his name, you can diagnose it. Who is this? Actually, this is Richard Burton. So what does Richard Burton go to do with a child in Kerala with abdominal pain? So you see the original oral cavity. You can see there is a line there. Can you see the line there? What is this line? This is the Burton's line. See the peripheral smear again. Hyperchromic microcytic anemia, and you can see basophilic stippling of RBC. See, all the diagnosis, lead poisoning or clumpism. His father was a plumber, a painter, and he had this child had severe pica. So he was maybe he was taking lead paint, or because of the pica he developed lead poisoning. Now this sometimes the pathology may be in the anterior abdominal wall, so it's very important for you to elicit what is known as the Carnot sign. I hope you know what is the Carnot sign. The Carnot sign may be positive in a condition called anterior cutation of enteropenile syndrome. It is a rare condition, but it causes severe pain, especially in the right iliac fossa, and hence it may be mistaken for appendicitis. It's a local pain in the anterior abdominal wall. In the evaluation, when we ask a child to show the site of pain, he will always draw. To my opinion, my experience, that the child will draw a circle around the umbilicus. So I call it as the umbilical sign. Okay, maybe a functional pain. Now, what is closed eye sign? The child with the functional pain is sure that the examiner is not going to hurt her. So when she is being examined, she may even keep the eyes closed. The closed eye sign is again a sign of a functional abdominal pain. What is the stethoscope sign? A child with functional abdominal pain is being examined by a tough-looking male PG, one of my best PGs. We can see that with the stethoscope, okay, he started to auscultate the chest and he's brought the chest stethoscope to the abdomen and is pressing hard the area where the child is complaining of pain. But you can see that the child is not at all bothered. He's not even looking at the doctor. He's decelerating, he's comic. But when the same child is examined by a nice-looking lady resident, he has dropped the book and is smiling at her. That is adolescence for you. So this is called the stethoscope sign in functional abdominal pain. I would like to thank all my brilliant models, my old PGs, actually my present PGs. Gokul is a famous neonatologist. Rajalakshmi is one of the best intensivists, and Vivek Raju, the tough-looking male PG, is a very nice person. He's a brilliant neonatologist. The investigations can be classified into 3 levels or 3 tiers. All patients with the chronic abdominal pain should be subjected to basic set of investigations like CB, CS, ALT, stool local word, and USC. This is the USC finding of mesenteric lymphomatosis. Now, I suppose we can discuss more about mesenteric lymphomatosis during our discussion, question and answer session, if you are interested. Level 2 investigation, if the patient has got red flag signs only, these are some of the level 2, whereas the level 3 investigations usually not triggered, but you are suspecting a condition like abdominal epilepsy, plumbism, porphyry, which are very, very rare conditions, maybe you have to do the level 2 investigations also. So what is the aim of treatment in chronic abdominal pain? Remember that the idea of the pediatrician should not be complete relief of pain, but we have to reassure the parents that you have investigated your child thoroughly and there is no underlying serious organic disease. You should constantly learn to normalize their daily activities. They should go to, of course, it's not possible nowadays because of COVID, but they should go to school. They should concentrate on playing, encourage them to focus on studies, extracurricular activities, and forget about the pain. Should never accuse a child of malingering. We should again realize, I would like to stress that point again, the pain that the child is complaining is really is never malingering. The genuine, it is really felt by the child. So regular and diligent follow-up are essential. And as pediatricians, we should ask them to avoid high FODMAP diet. And as antispasmodics like cyclopin may be detrimental because of the anticholinergic action. So in conclusion, chronic abdominal pain is usually functional, but we had always got to look for red flag signs. You should always investigate the child before labeling that the pain is functional. Reassurance the parents as well as child is vital. Treatment should be individualized. Now, Sir William Moser, the father of modern medicine, had remarked decades back that the young physician starts life with 20 drugs for one disease, whereas the old physician ends life with one drug for 20 diseases. And chronic abdominal pain is one condition, especially functional abdominal pain is one condition, wherein too many drugs should not be prescribed. So we should be like William Moser. Finally, Theodore Woodward, the famous physician, had once remarked that when you hear hoofbeats, think only of horses, not zebras. That is, think of only common conditions. But as pediatricians, I would like to change this dictum, and I would say that you should also think of zebras. Once you roll out the common conditions, you should also try to roll out the rare conditions, because if you do not do so, you may sometimes miss very serious organic conditions which may be amenable to treatment. And thank you so much for listening to me. Shall I stop staring?
Yeah, please.
Thank you, Dr. Riaz. Can you stop slide sharing? Yeah.
Yeah.
The next speaker is Dr. Malathi. We'll take questions in the end, so please put all your questions in the chat box. We will now listen to Dr. Malathi, and she's going to speak on neonatal cholestasis, which has been the bread and butter of pediatric gastroenterology for many decades. And our knowledge of that condition has improved quite a lot in the last few years. So today it's no more considered a surgical topic. It is a medical topic, and I think we do not send them neonatal cholestasis to a surgeon. The aim of this presentation is to tell you that at least 70 to 75% are medical problems which you should be able to handle. Dr. Malathi with neonatal cholestasis.
Good evening, everyone. I'd like to thank Dr. Jayaraman, Dr. Johnny Sebastian, Dr. Pramod, and especially Dr. John for initiating this program, even in 2021. After all that thing, we still want to do a very academic activity. My topic is, as Dr. John has said, it is neonatal cholestasis syndrome. And we all know what neonatal cholestasis syndrome is, but to reiterate, it is a heterogeneous group of hepatobiliary disorders, and that is why it is the problem. It is seen 14 days after life, because physiological jaundice, usually we take it up to that. And though we call it neonatal cholestasis syndrome, even if it occurs after the neonatal period, this is one condition. Even up to the age of 6 months, we still call it neonatal cholestasis. And the clinical presentation is a very classical triad of jaundice, high-colored urine plus or minus pale stool. So the high-colored urine is the one which is more significant, and the direct bilirubin is more than 1.5 milligrams percent or 20% of total. So all the features are much against what we usually see in physiological jaundice. The incidence is in 1 in 2,500 births, and in India it constitutes 1/3 of all chronic liver disease. So why the alert? What are these issues? Why do we keep on talking about neonatal cholestasis syndrome? In most of the CMEs, we like to stress this because we realize that it's a big basket containing several phenotypes. All of them have jaundice, but they are due to several different etiologies, and sorting them out between hepatocellular and obstructive is like a marathon. You have to do it very fast, but it's not very easy. And you have to choose an investigation. You can't do all the investigation for all the children. And the spectrum of treatment is so varied. It can be as simple as just changing the diet to liver transplantation, and the timing of surgery, especially for biliary atresia, because it is a dynamic disease, is very crucial. So it is a big basket of NCS, and so you have to differentiate. And little more, why this yellow alert, why this topic was chosen, because yellow alert, the term was used mainly to identify biliary atresia. But as Dr. John was saying, this is not yellow alert and NCS. You should not completely think only about the surgical cause. There are 70% of medical causes, which as pediatricians, some of them you may have to even manage. But biliary atresia is a dynamic disease, high morbidity and mortality, and you will lose the child by 18 months of age if no treatment is given. If you give treatment well within time, 30% of them will do well, 30% till the age by 13 years, 30% even at the time of surgery, less than 45 days, you may require liver transplant. Idiopathic neonatal hepatitis, 60 to 70% will recover. Metabolic liver diseases, many of them may require liver transplant. You may require antibiotics for the infections and antivirals for CMV, hepatitis B or HSV. So that is why the alert. So the alert should be so much that even before the parents are thinking about the cradle ceremony, that ceremony, this should be identified as early as possible and things have to be done. So there are main two divisions, as I was telling you. Like in little older children, when we have jaundice, we say hemolytic, hepatocellular, and we talk about obstructive. Here, majority of children, when they have jaundice, apart from the hemolytic diseases, they have only a cholestatic component, but their cause may be hepatocellular or obstructive. So the hepatocellular causes are several. The most important are the infections, the metabolic. In that, I will tell you what is important. A few endocrine, you could have prematurity. And in the obstructive causes, the phenotype is biliary atresia. So in the hepatocellular, the phenotype would be probably infections and metabolic, whereas the phenotype in obstructive is biliary atresia. So idiopathic neonatal hepatitis would probably the phenotype of hepatocellular, and the phenotype of this would be biliary atresia. What do we see in India? Do we see NCS in India? Yes, we do see NCS in India. And in NCS in India, early in 2008 centers, including the one from Chennai, we found that 50 to 60% of neonatal cholestasis syndrome in India is due to hepatocellular causes. At that time, we found idiopathic was 30%. But now, doing clinical exome studies, idiopathic has definitely dropped, and we find that metabolic and other causes are becoming more as we see the awareness because of the increasing knowledge. Whereas in the obstructive part, it is 30%. In that, it seems to be the same. Biliary atresia is the most common, with choledochal cyst being 4%. So I'm going to make it a very simplified approach because today we are talking about Pedgastro Simplified. So this will be the main thing which pediatrician should know. But you know there are exceptions to the rule. But if you follow these steps, majority of NCS you will be able to manage. So the first step is a good clinical and stool examination. A good clinical and stool examination. And then because we said physiological jaundice, the urine is not eye colored. You will never get a infant with physiological jaundice with urine staining the diapers. There will never be a hepatosplenomegaly. So when you see a child with that classical triad of jaundice, high colored urine, pale stools coming to you, the first thing you do is at least first give off that vitamin K. Then you have to examine the child nicely and you classify the child as sick child and not sick child. And when you look at the child itself, I think Dr. Riaz would be probably the person who really taught us about all these syndromes. When I read Riaz's book, I always found he's so good at syndromes, identifying. So spot diagnosis, you look at it down, you look diagnose it. Allergy, you have to diagnose it. Then you classify them as sick, not sick. So the clues to diagnosis is first the dysmorphic facies. You may pick up thyroid, you may pick up Down syndrome. IU infections, if the microcephaly is there, the petechiae. If you have a massive splenomegaly, think of a storage disorder. If you find a sick child, you will think of IEMs and other HLH. And then if there's a heart murmur, you may think of allergy and Down. So this is a classical Down syndrome. This is the chubby cheeks of citrin deficiency. This is the triangular facies of an allergy. And this is the complex of arthrogryposis, ARC, a cholestasis, a low GTP disorder. The next important one, as I was telling you, we have to look at the stool ourselves. The mother will always say yellow. She will not say, yellow. She will keep saying, either you must show her something or either do a rectal examination and see the stool for ourselves. So visual examination of the stool is very, 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 very important in neonatal cholestasis syndrome. If the stool is pigmented like this, golden yellow, a normal color stool, at the age of 30 days, 40 days, it is unlikely to be biliary atresia. Whereas if you see a chalky white stool, it is more likely to be biliary atresia. It's not that it will be, but it is highly an obstructive cause. Whereas if you have a pale stool, which I will show you later, it may be this or that. But a golden yellow stool will not be biliary atresia. So based on this principle only, the stool card was introduced in Taiwan, and more than 1 lakh babies, as soon as they were born, they were given this card and sent home, and they found that the cards written that the incidence and the picking up biliary atresia and neonatal hepatitis was much, much higher. Sensitivity of 89% and specificity of 100%. So the same principle, our pediatric gastrology colleagues are forming it probably on the discharge card of the newborn. At the back, we could put this, and a new one has been designed by Professor Yacha, where he's even put the urine color. So this is very nice. In Japan also, they have done that. 7 colors for the stool and 3 colors for the urine. And definitely we will be able to identify neonatal cholestasis syndrome much earlier. So the first message I would like to give to the pediatricians is clinical examination and stool macroscopic. You don't have to send it anywhere. You see the color of the stool yourself, and this is the very important step in evaluation. So then I was telling you, you look at this child and see whether the child, you've looked at this dysmorphic facies, you've done the clinical examination, you've seen the spleen size, you've seen the dysmorphic. Then if the child is sick, so suppose this is a 45-day-old infant is sick. Why is it sick? Features of sick infant are lethargy, poor feeding, hypoglycemia, seizures, uncontrollable coagulopathy. The baby has ascites, anemia, fever, sibling death, early death, maternal history of stillbirths. All these are classified as a sick infant. And you find that the INR is prolonged. Look at this, ascites already developing. The child is very peevish, sick. There's a lot of wasting even at this young age. Then you realize this NCS is not the classical biliary atresia which you see. There's something more in this. I just want you to remember these 5 causes which the baby can present even in the newborn period. You may get a call from NICU, the 28 days old baby presenting with direct bilirubin, with little pale yellow stool, not white, but the baby is sick, has little ascites. Think of tyrosinemia, think of neonatal hemochromatosis, galactosemia, mitochondriopathy, and HLH. So these are the main 5 causes of a sick infant presenting with neonatal cholestasis, not the white stool, a pale yellow or a yellow stool. And some of the features for tyrosinemia, you will find that persistently the INR is prolonged. You try to give vitamin K, it is not corrected. You then give an FFP, after some days it again becomes. So that is a clue. And you will find the alpha-fetoprotein very high. Normally in newborn itself, it will be very high, but this will be extremely high. Neonatal hemochromatosis is another allogenic disorder. Galactosemia, you know, the persistent vomiting. As soon as breast milk is given itself, the infant starts vomiting, they have cataracts, and you will find the non-glucose reducing substance positive in the urine. So the message too is, when you find a sick infant, exclude sepsis, think of the possibilities of the 5, send for alpha-fetoprotein, do the non-glucose reducing substance for galactosemia, send for serum ferritin. If you find the baby has fever, HSM, nodes, and you find high ferritin, you find that there's something beyond, you can even do a bone marrow. And if you are suspecting neonatal hemochromatosis, you may have to do a biopsy from the lip for the iron. Mitochondrial hepatopathy, a simple test is doing and getting a high serum lactate. Then, as I told you, that you see a group of children who are not very sick. They may have pale stools, they may have white stools, or they may have golden yellow stools. So if you have this baby who's 45 days old, eye-colored urine, it's a pale yellow stool. There's been some admission in the day 7 with lethargy, but otherwise the baby is all right. The liver and spleen are enlarged. Then there's the other child with having, the previous one was a golden yellow stool. Then you have another baby with a pale yellow stool. And then you have this third baby with a chalky white stool. All these 3 babies have come to you. They are not very sick. They've been going, they've even come for the first immunization. And then you wonder what is happening. So all these 3 babies, as I told you, they do have cholestasis. But as I mentioned earlier, the case 2, which had the yellow colored urine, the motion is unlikely to be biliary atresia. The case 3 may be biliary atresia. The 4th one, chalky white, is probably biliary atresia. So which biochemical investigation will help in neonatal cholestasis syndrome? Actually, liver biochemical investigation will not help you to differentiate between the different etiologies at all. Bilirubin direct will be high, OTPT may be this way, that way, alkaline phosphatase will be high. But there is one finding. Suppose you get that. If you find gamma GTP low or normal, when you think it should be high, because we know gamma GTP is an enzyme, cholestatic enzyme, so it should go parallel with alkaline phosphatase. So if that has not increased, then probably you can think, as it was in this case too, with the yellow stool, you can think of these 2 disorders, either bile salt transport disorder. There are 6 types, but only type 3, you will have a normal or a high GTP, whereas all the other bile salt transport disorders, you will have a low or a normal GTP, and also an inborn error of bile acid synthesis. So message 3 and message 4, one was clinical examination stool, then we said things. So 3 and 4 are gamma GTP should be included in under the biochemical test of the liver and included. Some of us don't even see gamma GTP. Gamma GTP should be seen and picked up with all babies of neonatal cholestasis syndrome, because it is the most important clue for a subset of metabolic disorders. You can just pick up that group that time itself and make a diagnosis. And finally, you may have to do a genetic studies, because now clinical exome studies have come. It may look costly when you think 17,000, but remember, you'll be doing all the unnecessary tests, which will come to nearly 35 to 40,000 if you have not done this. So this will finally give you the clue. So that is the next message. So the next thing is what to do. You've done a biochemical investigation. What will you do quickly? Parallel, you have to do something. The most important is you will do an ultrasound. You will do an ultrasound with a milk-free 4 hours milk-free fasting, because these babies, you can't keep them without anything. So you can give little water, you can give glucose water. So you do an ultrasound, and suppose you've done in case 2, it may be normal, or you may have some readings. You may pick up a polydockel cyst, or if you may pick up a small GB, or you may pick up an absent GB. Suppose you have a small GB and you have an absent GB. Small GB or an absent GB or a very contracted GB, even on 4-hour milk-free fasting, it is very, very likely that it is a biliary atresia. Straight away, you call the pediatric surgeon, tell him earlier itself that you have a baby like this, do a perioperative cholangiogram and proceed with Kasai. But suppose the ultrasound is normal, but still you think it is very, very highly likely to be biliary atresia, you can proceed with the liver biopsy. Nowadays, liver biopsy is recommended as a pre-operative test to increase the yield of diagnosis and also to rule out other causes which may simulate biliary atresia, like PFIC3, where you can have high GTP and will be just like biliary atresia, or in the second case which we saw, you may have to do liver biopsy. So ultrasound, so that case which we did, the case 2, a liver biopsy was done because we found that the gamma GTP was low. It is not biliary atresia. When you have gamma GTP low, it is not biliary atresia. This was PFIC2, and then clinical exome was done. So what happened for case 3 and case 4? They reported saying GB not visualized as baby was feeding. Do you think this is okay? A report like that saying baby was feeding, therefore we have not seen GB. Please remember that when we send for ultrasound in neonatal cholestasis syndrome, that what we are interested is only the GB. So they must give us the GB. So the answer is no, they cannot give us a report like that. It has to be repeated. You do send the baby back on a milk-free diet. You can give a little bit of glucose water or plain water, repeat it. Ultrasound is definitely useful for choledochal cyst, but you will get a normal GB and a functioning GB in hepatocellular or NCS. But in biliary atresia, usually it is contracted, it is less than 1.9 centimeters in size. It may not be visualized, or you may get what is the ghost sign, where it is very, very irregular. So this is triangular cord sign is more theoretical. We have not been able to see it as anything in our country. So this baby, both the case 3 and case 4 were repeated, and they found that case 4, the last one with the chalky white stool, the GB was small and contracted. So as I told you, that baby will go directly for Kasai, but case 3, the GB was normal. So message 5, after the biochemical, most important is an ultrasound done with a minimum 4-hour milk-free feed. Ultrasound is useful in diagnosing choledochal cyst. So this baby, as I told you, it was a small GB. We opened the abdomen, sent for the Kasai. You can see the beautiful triangular here. These are the fibrous area, none of the CBD not visualized. The pediatric surgeon had taken a very beautiful picture, and I actually fell in love with it. Beautifully, he demonstrated that area. He did a good coring, and he did a hepatogegnostomy at that site. And the next day, we were so happy to see a stool like this. 1 month later, a stool like this, and this is what we call it a successful Kasai. What is successful Kasai? 3 months after surgery, the bilirubin should be less than 2 milligrams per deciliter. And the reason for this successful Kasai, what we say is percentage of jaundice free was seen more when the Kasai was done less than 60 to 70 days. So that is the reason why we pick it up early, and the native liver survival is also more higher when the surgery is done less than 60 days of life. So the younger the baby, these two were the results, and that is why the stress of doing Kasai as early as possible, so you get a successful Kasai. So the simplified approach to a suspected biliary atresia is you exclude biliary atresia when the baby is not sick. Usually, as I told you, the babies which I showed you the picture, they are representative. They are real children with biliary atresia. They have pale stools. They may have a small or absent GB. Suppose the baby is less than 6 weeks. HIDA is optional. Baby will take it up in the question time. You can do a liver biopsy and proceed. But if the liver biopsy is conclusive, you just proceed with POC and Kasai. Age more than 6 weeks, don't waste any time. Just liver biopsy, proceed with Kasai. Age more than 90 to 120 days, but there is no ascites, normal albumin, prothrombin time is normal. You again proceed with Kasai. But after 120 days, if there is decompensation, if there is ascites, no use doing Kasai, you have to send them straight for liver transplant. So this is a very simplified approach. Please keep this in mind. You can send the babies for Kasai later, but their liver function should be good. And if they are less than 6 weeks and more than 6 weeks, you can do a peroperative liver biopsy and proceed, because there are reasons why you do a liver biopsy before starting. So the case 3, as case 4 I told you, was a classical biliary atresia. We did the Kasai. Case 3, we did the biopsy. This child you saw had a high GTP. So this became PFIC 3 and was confirmed by the clinical exome studies. So the message 6 and 7 are liver biopsy is very helpful in differentiating, and you have to refer the baby early for Kasai. So as pediatricians who are listening, what can you do? Because you are the ones who are going to refer to us. And as a team, we are going to manage this case. This is not to be managed only by the pediatric gastroenterologist or by the surgeon. It is a team. Most of the babies who I have also worked up are always referred by the pediatrician. So you ensure that they get their nutrition 120 to 140 calories per kg with 85% fat as MCT, because the bile is not coming there. You have to give them their vitamin K, D, A and E. Water-soluble vitamins give twice the daily dose, and you give cholerytics till the definitive treatment is done. And what are the definitive treatment options? Suppose by the first thing you have made a diagnosis of UTI, sepsis as the cause of NCS. Be very happy. These are treatable causes of NCS, hypothyroid. All the babies are not biliary atresia. All the babies are not tyrosinemia. If you made a diagnosis of tyrosinemia, as I gave you the clues, you can give NTBC if it is available, but if not available or not responsive, quickly send them for transplant. Galactosemia, as soon as you even suspect, even day 1, this is one condition, you will not give breast milk, even on day 0. You may not give if you get that urine screening very quickly. Neonatal hemochromatosis, you will get from the family history, allergy, later you may have to do a biliary diversion. What are the indications for liver transplant? In biliary atresia, it may be a failed Kasai, or if they've come late, or a poor hepatic synthetic function. In metabolic disorders like tyrosinemia, in all the PFICs, we do except in PFIC 1 because it's a multi-system disease. In allergic syndrome, if the quality of life is poor. So, the listeners who are there, I would like to give you 7 important messages before I conclude my talk. Clinical examination and color of the stool, very, very important. When a baby comes to you, just relax. Don't get worried. Is it biliary atresia? Is it biliary atresia? Just relax. See the baby. Classify it as sick and not sick. Once it's sick, you exclude sepsis and the 5 conditions I told you. Look at the biochemical parameters. GTP, very important surrogate marker to pick up a subset. Do an ultrasound. Check whether the ultrasound was done 4 hours milk-free diet. Then, if you have a very good pathologist who's dedicated to see pediatric hepatology, very, very essential, very important, you can do a preoperative liver biopsy. But if your time is running very fast and you don't have, you can proceed to a mini lab, do a peroperative cholangiogram and proceed with the Kasai if your mind is thinking only of Kasai. Clinical exome studies have helped us a lot, especially in the not sick babies or the sick babies where we are suspecting metabolic and genetic disorders. Kasai to be done as early as possible, 45, 42, 43. Do it as early as possible because the results have been good. And liver transplant should be kept in mind when Kasai fails or any other condition as first therapeutic option. And thank you for your patient listening.
Thank you, Dr. Malathi. We will take questions in the end. Yeah. My slides are visible, I hope.
Yeah.
Yes. The topic that I'm going to speak on is pancreatitis in children. I think it's an important topic and not very often discussed because I think people think pancreatitis is rare in children. The aim of my talk today is to sensitize you to the fact that pancreatitis is far more common than we think. And wherever I have given this lecture on pancreatitis, the diagnostic numbers on pancreatitis suddenly go up, and I get multiple phone calls saying that they've diagnosed pancreatitis. So hopefully after my talk, you will have an avalanche of pancreatitis in Kerala. Here's a 7-year-old boy who presented with severe upper abdominal pain and vomiting of 3 days duration. Non-bilious, without fever or diarrhea. On day 1, the pediatrician had done routine tests and done an ultrasound, which was reported as normal. And the favorite diagnosis for all pediatricians is acute gastritis. It's never made sense to me how acute gastritis occurs so commonly. Child was started with IV fluids and kept nil orally. The symptoms worsened, the urine output reduced. A surgical consultation was made. Luckily, the surgeon didn't want to operate and child was referred to me. The person in casualty found that the child was sick and child was in pain. There was tachycardia and mildly low blood pressure. Child was febrile, dehydrated, and the child just did not allow the doctor to do an abdominal palpation. The other systems were normal. Routine investigations the doctor sent. By the time the ultrasound came, the ultrasound was suggestive of acute pancreatitis. The serum amylase takes a few more hours to come. It came as 974 and a lipase of 213. A diagnosis of acute pancreatitis in shock was made. With this case in mind, let's discuss what pancreatitis is all about. What is pancreatitis? It's a local or a diffuse inflammation of the pancreas. Local means it can only be head of the pancreas, or it can be the whole of the pancreas, or only the tail of the pancreas. And clinically presents as epigastric abdominal pain and vomiting. And on investigations, you will find an elevated serum amylase or lipase. Pancreatitis can be acute or chronic or in between, an acute recurrent. It can be inherited or it can be acquired. There's a varied etiology, but in children, as of now, it's still mostly idiopathic. But I think we are learning more and more etiological causes similar to what the neonatal cholestasis that Dr. Malathi spoke about. Significant mortality and morbidity if it is not recognized. What are the issues that are there with pancreatitis today? One is a lack of early suspicion. We just need to get pancreatitis into our differential diagnosis of abdominal pain in children. Pitfalls in using amylase as a sole diagnostic tool. We miss, depending on the day of illness it is. Difficulty with diagnosis on ultrasound because pancreas is a retroperitoneal organ. And unless you have a good sonologist who will routinely look at the pancreas, it's often missed. Particularly a pancreatitis involving the tail of the pancreas is very often missed unless they look for it. A lack of understanding of the pathophysiology often leads to a problem. Poor medical management in the acute stage. Children are missed for 3 and 4 and 5 days, by then complications coming. And no effort is made to detect any underlying cause. They are treated often without a diagnosis and sent home. Not diagnosing and managing complications as they do. And last, the issue of cost factor in adequate enzyme supplementation. These are all the issues that we come with pancreatitis in children. Now, what are the causes of pancreatitis in children? There are 5 or 6 common causes is what I have marked in that last yellow, the deep yellow. Valproate, mumps, pancreas divisum, biliary tract disease, genetic mutations, and blunt trauma. Today, blunt trauma is being increasingly recognized all over India. Earlier, it was seen to be only in the West. But remember that idiopathic is still the commonest cause of, or that we don't know the cause of pancreatitis in children. But you must make an effort to look at some of these causes. I have seen all these causes that are mentioned there in the first half of that slide. So please look further. When should you suspect pancreatitis? I said I want more pancreatitis to diagnose. So when and how are you going to do it? One is a child with an increasing epigastric pain followed by persistent vomiting and no fever, and the casualty medical officer or the doctor writes their gastritis. Please remember, gastritis is not common. The stomach mucosa is equipped to deal with acid. So how on earth can you get gastritis? It's maybe common in adults, but not in children. Fever, increasing upper abdominal pain, vomiting, and dehydration. You make a diagnosis of dengue. Also think of pancreatitis. Fever, tachycardia, guarding, and tenderness. People think of peritonitis and calling the surgeons. Please call the surgeons, but also look at pancreatitis. It's disastrous if you have to go and open a child with so-called peritonitis and find that it was a pancreatitis. Mild jaundice, fever, right upper abdominal pain, food-induced vomiting, and you diagnose cholecystitis. Ultrasound is non-specific. Think of pancreatitis. Vomiting, low fever, diffuse abdominal pain. You make a diagnosis of gastroenteritis. viral or bacterial, whatever, think of pancreatitis. Favorite diagnosis in casualty by the medical officer is vomiting query cause. Whenever you put down a diagnosis of vomiting query cause, please think of pancreatitis. And often you will find that you are unknowingly treating a pancreatitis with all these diagnoses, because you will keep them nil orally, you will give them IV fluids, but all you would have done was to have missed the diagnosis, because the child will come back with a recurrence of that pancreatitis later on. How do I diagnose pancreatitis? Clinically, upper abdominal pain and persistent vomiting, serum lipase that is 3 times the norm. Remember, lipase rises in 4 to 8 hours, peaks at 24 hours, and it remains high for up to 14 days. It's 100% specific for pancreatitis. Whereas serum amylase has a high sensitivity but a low specificity, because it's also produced from the salivary glands, but it's more easily available. It's easier to do, cost less, and it's freely available. Remember that it rises more quickly. So if you have a child who comes within a few hours of pancreatitis, your amylase will be more sensitive than a lipase. Peaks at 48 hours, but remember that it returns to normal by 5 days or at best 7 days. So amylase rises early and comes down earlier. Lipase rises a little later but stays elevated longer. You can do an ALT and GGT if you think there is a biliary tract disease. Always do a hematocrit, a PCV, because it indicates severity of disease. And a high hematocrit means there is hemoconcentration and hypovolemia. And that's really bad, because if you have hemoconcentration, it means that the pancreatic perfusion becomes less in a pancreatitis, and that leads to pancreatic necrosis. So the last thing that you want is a child with pancreatitis having worsening hematocrit. You want the hematocrit to come down, the hemoconcentration to be corrected as quickly as possible. What is new? Serum trypsinogen activation peptide is just coming into the market. Good specificity. Urine trypsinogen 2 is a test that's now available. Very rapid. You can get your test within 1 hour. It's an indirect measure of the trypsin in the blood, the urinary trypsinogen measurement. Very high specificity, and it correlates with severity. I've been doing it for the last couple of years, and I find the correlation with the clinical diagnosis is excellent. Urine dipstick tests can be done in the ER for screening. It's just coming into India, but sooner or later it will come, and if dipstick comes in, then it can be used as a screening test in the ER itself, so that you can make diagnosis. The next question is, what's the role of imaging in acute pancreatitis? Ultrasound abdomen is the first and the best investigation, provided your sonologist is good. But remember that a normal study does not rule out acute pancreatitis, partly because of the visibility of the pancreas in many situations. CT scan is best avoided in the acute stage, because when you give a contrast which is very hyperdense, it further reduces the blood flow to the pancreas and worsens the ischemia and thus the pancreatitis. So only if you suspect a pancreatic necrosis should you do a CT scan. Otherwise, please do not order a CT scan. An ultrasound is the best. MRI cholangiogram will detect a biliary tract disease, gallstones, and even biliary tract anomalies or pancreatic anomalies. But we usually reserve that later on after the pancreatitis has settled. So for imaging, all practical purposes, a decent ultrasound abdomen is sufficient. What's the criteria for diagnosis? This is called INSPIRE criteria. Very useful. Any two of these three. Abdominal pain compatible with acute pancreatitis, serum amylase or lipase thrice normal. Remember that it should be thrice normal. And an imaging finding compatible with acute pancreatitis. Any two of these three is enough for you to make a diagnosis of acute pancreatitis. Just for completion, I'm going to tell you the INSPIRE criteria for chronic pancreatitis. That's any one of these three. That is abdominal pain of pancreatic origin, plus an imaging suggesting CP, or an exocrine pancreatic insufficiency, like fat in the stool, etc., plus an imaging suggesting of CP, or endocrine pancreatic insufficiency, plus an imaging that suggests chronic pancreatitis. So any of these three, any one of these three is enough for you to make a diagnosis of chronic pancreatitis. Any two of the above is enough for you to make a diagnosis of acute pancreatitis. Now, Classification of severity of pancreatitis used to be very difficult earlier. Luckily for us, it's now been simplified, and this is the simplified classification of severity of acute pancreatitis. You diagnose pancreatitis by the INSPIRE criteria. And the question you ask yourself is there any organ dysfunction? Is there a renal dysfunction, cardiac dysfunction, or respiratory dysfunction? If it is there, you follow that for 48 hours. If it is not subsiding in 48 hours, the organ dysfunction is persisting, you call it severe acute pancreatitis. If it is subsiding within 48 hours, it's transient, it goes away, then you say this is a moderately severe acute pancreatitis. If there is no organ dysfunction at all on admission, then you ask, is there any local or systemic complications? If there are no local or systemic complications, you called it mild acute pancreatitis. If there are local complications like a pseudocyst or something like that, or systemic complications, then you call it a moderately severe acute pancreatitis. All previous classifications of severity are gone. Very simple classification. All you decide is there any organ dysfunction? Second question, any local or systemic complications? And you can classify the severity of acute pancreatitis. How does one manage acute pancreatitis? The key is fluid resuscitation. You must make sure that the pancreatic microcirculation is adequately hydrated so that the cytokines and everything go away. The pancreas is adequately perfused so that the inflammation subsides faster. 150 ml per kg of fluid, enough to ensure a urine output of at least 1.5 ml per kg per hour, is the key to getting a good outcome in acute pancreatitis. Adequate analgesia, you can use an opioid if required because the pain is very severe. And pain often leads to tachycardia and hypotension and a whole lot of problems. So abolishing pain is paramount. You can use an opioid if required, but somehow you must make sure the pain goes away. Monitor pulmonary, cardiovascular, renal, and metabolic status, as I said, because you decide on your severity based on that. And you start enteral feeds early. Do not keep them nil-orally for long. It has no advantage whatsoever. What I do is to start them on feeds as soon as the children say they are hungry or they are thirsty. They want to take some food. Their hunger and thirst is a sign that the disease is settling. The stomach is ready to receive feeds, and that should give you a good outcome. No role for prophylactic antibiotics or probiotics. No proven efficacy for PPIs in all the studies, but I can tell you that everybody gives it. Repeat ultrasounds to watch for pancreatic necrosis or pseudocyst if the baby child is not improving. What are the interventions that may be necessary in acute pancreatitis? There is a long list of them, but in practice, most of our children adequately manage, develop none of these complications, and need very little intervention. Here's another case. He's a 14-year-old boy with recurrent abdominal pain, which was more after food. Poor appetite and food refusal at home. Eats out sometimes, and the doctors say that when he comes with pain, they make a diagnosis of food poisoning. His sleep was disturbed from abdominal discomfort, not on any long-term drugs, and there's no family history. The ultrasound showed gallbladder sludge and mesenteric lymphadenopathy. The LFT and blood counts were normal. I retook a history, and the history was that whenever he went out, he ate fried rice and parota with his friends, and that night he would develop pain. Next day he will go to the doctor, and the doctor will say this is food poisoning. But significantly, he has lost 4 kilos in the last 1 year. Never ignore a weight loss in a child who comes with any GI symptom, not just in the context of pancreatitis, in the context of any illness. Weight loss with any symptom referable to the GI tract is pathological. It is not functional. A repeat ultrasound showed a dilated pancreatic duct. That's all it showed, just a dilated pancreatic duct. His lipase and amylase are only mildly elevated. An MRI cholangiogram confirmed the diagnosis of chronic pancreatitis with atrophy, but there was no calcifications. So what is chronic pancreatitis? It's a progressive inflammatory disorder of the pancreas characterized by irreversible morphological changes and fibrosis, leading to permanent pancreatic insufficiency. That's important. This is a chronic process. It's a progressive process. It's an inflammatory process. And the end result is pancreatic insufficiency. Starts with exocrine and later on leads to endocrine. 3 types: calcific, obstructive, and inflammatory. Calcific is not uncommon, and I think in Kerala it will probably be more of calcific pancreatitis. When should you suspect pancreatitis? Any child who comes with a recurrent prolonged abdominal pain, pain that lasts for many days, think of pancreatitis. Nausea, vomiting, and anorexia of unexplained origin, think of chronic pancreatitis. Features of maldigestion absorption. When you say giardiasis, for example, recurrent giardiasis, people going on giving anti-amoeba drugs, think of chronic pancreatitis. Weight loss, GI symptoms with weight loss. Vitamin A, D, and K deficiency in an older child, which is not common. Obstructive jaundice plus or minus diabetes. All these are features which should alert you to the possibility of chronic pancreatitis. How does one diagnose pancreatitis? I showed you the INSPIRE criteria for diagnosis of chronic pancreatitis. And in biochemistry, remember that amylase and lipase may be normal. Even if it is abnormal, it's only mild. Because unless there is active significant destruction, these enzymes are not elevated. So a normal amylase and lipase does not exclude chronic pancreatitis. And that's the difference between acute and chronic pancreatitis. ALT, GGT, etc. you do to rule out a biliary obstruction, because biliary tract disease can lead to reflux of bile into the pancreas and give you recurrent chronic pancreatitis. Postprandial blood sugar should be done to rule out diabetes, because that is a better indicator than fasting blood sugar. Pancreatic function tests to rule out pancreatic insufficiency, and the easiest thing to do is to do either a 72-hour fecal fat or just a steatocrit. Like you do a hematocrit, take the stool in the capillary tube, spin it, and see how much of fat is there on the top of that stool. If it's more than 15% of the top of the total stool length, then it is very suggestive that there is pancreatic insufficiency. It's a very simple bedside test that you can do, and it's got a high specificity. Fecal trypsin and elastase are now available. It can be done, and it's quite useful in a chronic pancreatitis. Ultrasound is the most helpful investigation even for a chronic pancreatitis. What you are looking for is the pancreatic duct diameter. So whenever you send the child for an ultrasound for the pancreas, please tell them to specifically look at the pancreatic duct dilatation. A duct dilatation in the pancreas, except in the very acute stage, always tells you that there is chronic pathology. Less than 1.5 millimeter for those below 6 years, and less than 2.2 in adolescents. That's the upper limit. Anything above that is considered as pancreatic duct dilatation. Calcifications are very easily picked up, better than a CT scan as an ultrasound. Intraductal stones can be visualized. Endo ultrasound can be done for early diagnosis, but I think the experience is limited. And I think the key is to tell the sonologist what to look for. Tell him to look at the pancreas. Because often when children come with abdominal pain, you go straight look for appendix. Appendicitis is not uncommon, but pancreatitis is equally common. Tell them to look for it, because they often do not look at it. MRCP in chronic pancreatitis will confirm your pancreatic duct dilatation, also tell you the caliber of the duct. Being non-invasive, today it's preferred to ERCP, and you do ERCP only for therapeutic interventions. For diagnosis, an MRCP is more than enough. And unlike an ERCP where you go and inject, it becomes a non-physiological state. An MRCP is a physiological test. So you can actually see in a physiological state how the duct and the pancreas are. Problem is a poor signal intensity. Patients may not cooperate. And sometimes in small children, it's difficult to visualize a small duct. So if you are doing an MRCP in a small child, make sure the child is adequately sedated. Do not try to do an MRCP on a child who is uncooperative or partially cooperative. You need to have a very good sedation so that you get what you want, because you are looking at subtle changes. Genetic tests in chronic pancreatitis, we are increasingly recognize them. SPINK gene, CFTR gene, PRSS1 mutation, they are all there in this country. And now the genetic tests are available. We are picking them up. Children who come with recurrent acute pancreatitis or with a chronic pancreatitis, I think are candidates for you to do mutation studies. The three main issues with chronic pancreatitis are chronic pain syndrome. Pain is a major problem. Malnutrition and long-term is diabetes. Pain management is crucial. Non-narcotic analgesics, you can use NSAIDs or tramadol, or narcotics in low doses and step it up gradually as necessary. In non-visceral pain in pancreatitis, you can use gabapentin, good drug, and that is preferred to antidepressants that we were using earlier. Gabapentin is a very good drug for non-visceral pain in chronic pancreatitis. Maldigestion, enzyme is available now, lipase, 30 to 60,000 units per meal. Ideally, half at the beginning of your meal and half at the middle of your meal. Uncoated preparations are better than coated. May open the coated capsule and sprinkle over a meal in small children who cannot swallow the capsules. Uncoated preparations are more effective if you use it with a PPI. So that's what about enzymes are available. Unfortunately, it's a little expensive. So if you need to give so much, it works out to a big cost. I normally recommend that they go on medium chain triglyceride based diet and plus some enzyme supplementation, because it reduces the amount of enzymes that you need to give. 10,000 or 25,000, it's quite expensive. So use in Kerala coconut oil is the best to use because it's very high in MCT. So you can use more of coconut oil and thus reduce the amount of enzyme supplementation that is needed. Monitoring the response to enzyme therapy is one, by growth of the child, and second, whether there is any steatoria. You can do a steatocrit if you want fine management. It's a very easy thing to do. What are the poor response reasons to enzyme supplementation? One is that the enzyme may not be very potent. Companies may not be really putting in the 10,000 or 25,000 that they are claiming. Improper timing of the enzymes. As I said, you have to give it at the beginning of the meal and halfway through the meal. Increased intestinal motility means there's no time for the enzymes to act. Non-compliance is the commonest reason as far as I know, and the main reason is that is financial. So try and reduce the dose of enzyme that you give so that you get better compliance. So change the diet, lower the dose of enzymes, your compliance is always much better. And wrong diagnosis. Maybe the child did not need enzyme supplementation, or your diagnosis of chronic pancreatitis was incorrect. What's the summary of my talk? Acute pancreatitis in children is usually mild, but recognition may help prevent morbidity and mortality. Suspect whenever you put a diagnosis of gastritis, vomiting query cause, peritonitis, prodromal acute gastroenteritis, recurrent abdominal pain, or chronic diarrhea. Whenever you put from today on, please think of pancreatitis. It may not be, but think about it. Prefer lipase over amylase because it's more specific. I'll prefer ultrasound over CT, and you do an MRI later, not during the acute stage. Early adequate fluid resuscitation is the key to a good outcome in acute pancreatitis. Imaging is key to diagnosis of chronic pancreatitis, unlike in acute pancreatitis. Pain management and enzyme replacement are vital in your management of chronic pancreatitis. Thank you very much, and we will take on questions later on. Let's now move on to our last talk, and the lecture will be given by Dr. Sumathi, and she will speak on GER and GERD. Dr. Sumathi. Sumathi? Can you share your slides?
Yes, sir. I'm doing that. Good evening, everybody. At the outset, I would like to thank Dr. T.P. Jayaraman, sir, Dr. Johnny Sebastian, Dr. Pramod, sir, and all my senior faculty members of ISPAGAN for giving me the opportunity. Introduction. We all know that GER is not uncommon in children and is a major cause of concern at all ages. And symptoms can be non-specific in infants with a lot of differential diagnoses. And signs and symptoms in children can be esophageal or extra esophageal, and they also depend upon the age of the child. What is GER and GERD? Gastroesophageal reflux is a physiological phenomenon which is an involuntary passage of gastric contents into the esophagus with or without regurgitation and vomiting. Whereas GERD, that is a reflux disease, is a pathological form of GER resulting in symptoms that affect daily activities with or without complications. So this is definitely a pathological phenomenon, whereas GER can be a physiological phenomenon in young infants. And refractory GERD is a one that is not responding to optimal therapy of drugs even after 8 weeks. Why to suspect GERD in children? We all know that subclinical GERD is the most common type, and the disease per se just says the tip of the iceberg. And less than 10% of children only seek medical attention, and complications do occur in children, and it is around 2%. And in general, children with GERD, if not recognized and treated, they can have malnutrition, they can have impaired quality of life, impact that is interfering with the daily activities and studies, and in late complications like peptic stricture, and sometimes even Barrett's epithelium, and very, very rarely even adenocarcinoma, though it is rarely reported. These are the things that can occur in a child if it's not treated and recognized at an earlier stage. GERD is always GI related? Definitely not. It can be esophageal as mentioned earlier or extra esophageal. In infant, the esophageal symptoms can be even non-specific like irritability, fussiness, feed refusal, vomiting, failure to thrive, arching of the back, Sandifiers-like syndrome, and unexplained anemia. And in older children, the typical symptoms of GERD can be heartburn, chest pain, epigastric pain, rarely even they can present with GI bleed and dysphagia. In extraesophageal symptoms, the conditions these can be recognized with recurrent wheeze, recurrent pulmonary aspiration, acute life-threatening event in a young infant, laryngitis, otitis media, sometimes change in the voice, and rarely even dental erosions. Thus, these indicate GERD is less a spectrum with different symptoms of esophagus and extraesophageal. So high index of suspicion is very, very essential because the signs and symptoms vary with the age of the child. What are the red flag signs? Why should we know the red flag signs in a child coming with vomiting or regurgitation? We all know that vomiting is a non-specific symptom. It can occur with many of the disease conditions, especially when vomiting occurs in a child less than 7 days old. You should keep thinking of an IHPS, infantile hypertrophic pylori stenosis, rarely malrotation, upper GI obstructions conditions, and if seizures, liver and spleen are palpable, one should think of a metabolic disease, and cough, choking, one should think tracheal fistula, and fever, lethargy can be due to some systemic infections or the central nervous system infections. An altered bowel habit, especially constipation, one should think Hirschsprung disease, which can present with vomiting, and in older children, they can just present with vomiting can occur many of the conditions like cyclical vomiting syndrome, ulcer disease in children, and rumination disorders. So these are red flag signs. Based on the red flag signs, one has to differentiate which the child is having, whether it is a GI symptom or a non-GI symptom. Based on that, referral has to be given so that it can be treated accordingly. Let us go through the case scenario. A 5-month-old child on exclusive breast milk. The mother gives history of regurgitation of milk feeds with occasional vomiting containing curdled milk. The weight is normal, the weight gain is normal, and the alarm symptoms are not there. On examination, child is normal. So what is the diagnosis? The diagnosis is happy spitter. Why happy spitter? Because the child is happily growing well, no alarm signs and symptoms, just spitting out small quantity. Do we have to investigate? How do we manage? GER physiological in most infants and no investigations are needed. The treatment is just reassurance, only reassurance, because this is only physiological. Most of the infants, they outgrow the problem by 12 to 24 months. Less than 10% only they go for GERD reflux disease. So we have to just reassure the mother. No need for any investigations. The second case scenario is a 9-month-old child on cow's milk feeds. The mother gives history of persistent regurgitation. The previous case, it was only occasional, whereas here it is persistent regurgitation, which indicates something problem with the child, and vomiting of curdled milk. More important is failure to thrive. So failure to thrive is a red flag sign here. This is an incessant cry is a red flag sign here, and regurgitation is also a red flag sign. So this is a disease phenomenon, not a physiological one, unlike the previous case. So how should we manage? As mentioned earlier, the good history and thorough physical examination is very, very useful in a child with recurrent vomiting or regurgitation, and look for alarm signs. The persistent regurgitation and failure to thrive indicating the child has got some problem, needs a important issue. So how do we investigate? So before that, we have to look for another clinical examination that is going to give a clue. So who are the children they are prone for GERD or recurrent vomiting in a child? One should go back to the birth and neonatal history, whether term or a preterm child, whether the child had any birth asphyxia, any step surgery in the immediate newborn period, look for any esophageal fistula and development of the child, because neurologically impairment child or any child with motor neuron disease and spinomuscular atrophy, developmental delay, both mental and motor retardation can have a reflex disease. And most important, because recently we are seeing a lot of children, especially older age group, with obesity. So these are the important clue or the examination we have to carry out, because these are children, they are prone for GERD in day-to-day practice. So what is a diagnosis? Here we have to suspect GERD and it is pathological. How will you manage? As mentioned, signs and symptoms in infants may be non-specific, because incessant cry and failure to thrive can occur in an umpteen number of conditions. So this child is alarm symptom requiring referral and further investigations. So what is the role of positioning in general in a child with vomiting or regurgitation? We all know that prone position, though reduces the frequency of reflux, they are prone for SIDS, sudden infant death syndrome, hence not recommended, and supine position is preferable. However, head and elevation of crib in a young infant and use of chairs can compromise respiration because it increases intra-abdominal pressure, hence not advisable unlike older children. So positioning, just we can advise a mother if you feel there is vomiting before embarking on a therapy. Let us go to the third case scenario. This is a 1 year and 9-month-old boy with recurrent vomiting. So recurrent vomiting is an alarm sign here, and streaks of blood. Blood in the vomitus is always pathological, whether it is minor or major. And he is also restless after feeding, indicating some mucosal injury because painful, causing some refusal of feeds and not taking solids and not gaining weight. So this is definitely a child, a young infant having all the alarm signs along with vomiting of blood. So these children need definitely you have to investigate. But what other investigation, any other history we need before going on to any investigations? So we have to ask the mother, what is the feeding? What is the volume? Whether it is very osmolar, dense feeds or any allergen, early introduction of cow's milk, though it is less commonly seen in India, but you can eliminate if it is there. And any clothing, mother wearing the clothes, too tight clothing. Sometimes the present era just put this young infant in the car with bells. These are things that can trigger reflux in a young infant. So we have to go back to all the history. Apart from a good physical examination, look for the alarm signs. There's a different system examination, a CNS, a liver, spleen, anemia, whatever it is. So we have to go by the general examination. Why think of GERD in this child? Blood in the vomitus, irritability, incessant cry, failure to thrive, and not taking solids. All these things are very, very important alarm or red flag signs. So we have to investigate. So what are the investigations do we have to subject the child? A complete hemogram is a must because we have to look for anemia. Anemia per se can reduce the weight in the child. Child can lose weight. They will not have appetite, all those things. Apart from the endoscopy. Anemia can give a clue whether it is a chronic GI blood loss due to reflux disease, and endoscopy, why endoscopy? So this child needs definitely a referral to a specialist for further investigations. Endoscopy is a must because blood in the vomit indicates there is a mucosal injury. Why endoscopy, as mentioned earlier? It allows a direct visualization of the esophageal mucosa, and we can take biopsy to look for evidence of GERD. The histopathology evidence of GERD, we have to think for any hyperplasia of the basal cells and elongation of the T-pegs. And what is the other use of doing endoscopy in children with suspected GERD? One can assess the competency of the lower esophageal sphincter. We can assess for any evidence of hiatus hernia and achalasia cardia, dilated esophagus with stasis and tightening at the sphincter, LES. One can think I'm dealing with a case of achalasia, though in early stages endoscopy may be normal. And most important, eosinophilic esophagitis in especially older child where they can present with dysphagia and food bolus impaction. We should think of this entity, and biopsy is a must to rule out this condition because the treatment is different along with PPA. The complications, one has to look for complications, especially older children, not at this age, but peptic stricture in adolescent or older child, and in later stages, Barrett's metaplasia. These are the uses of endoscopy in a child with suspected GERD, and especially in this kid because of the vomiting of blood, one has to document a mucosal injury because we have to treat the child with PPA. How to manage? So any age, whatever be the age, if there is evidence of mucosal injury, then we have to give proton pump inhibitors, the first line drugs for 4 weeks, and if there is a response, and we have to slowly taper by 4 to 8 weeks. And the feeding advice is very, very important. This child, so based on the age of the child, if the child is less than 6 months, only exclusive breastfeeding. More than 6 months, along with the breastfeeding up to 2 years, and complementary feeding based on the age and custom, the habit in the family, and we have to advise with the proper positioning. And important is regular follow-up, because we have to always keep a follow-up to look for the growth of the children. Let us go to the third case scenario. A 10-year-old boy weighing 54 kg. And he gives history of regurgitation, back pain, heartburn on and off for 2 years. So definitely he has the typical symptoms of regurgitation, he has back pain due to retrosternal involvement, and heartburn, all this indicating there is a reflux disease. And the weight is 54 kg, which is very, very high, indicating child has got obesity. Why GERD? The risk factors as typical symptoms of GERD, and children more than 8 years can verbalize the typical symptoms, unlike young infant. So in infants, it is very, very difficult to get the history of GERD, whereas in older children, based on typical symptoms, here we have a role for empirical PPI before doing investigations if there are no alarm signs. A good history and physical examination is a reliable factor, around 60 to 70% in older children and adolescents. So this history is very important. Always examination, look for that weight and height, especially because obesity is on the rising trend now. So already mentioned how to manage. So PP has a role as an empirical therapy in this child because of older age, lifestyle modifications. He has got typical symptoms. And what are the lifestyle modifications we have to advise? A gradual weight reduction, avoidance of high fatty food, chocolates, passive smoking, even alcohol in adolescent age group, avoiding late night dinners. These are the lifestyle modifications along with PP for a course of 48 weeks, in initial period 2 to 4 weeks, looking for the response is very important in tackling GERD in this age group. Most important is always a obese child. They are prone for other, even you have to look for the acanthasis nigricans, whether he has got other problems as a gastroenterologist apart from tackling GERD alone. If no response, what is the problem? So these are children who need referral for further evaluation, including endoscopy and other investigations. So what are the indications for upper endoscopy apart from GA bleed in a child with GERD? Hematemesis, as already mentioned, failed medical therapy is one more indication, unexplained anemia, and prior to surgery. Dysphagia, already mentioned, may be due to peptic stricture, and we have to keep a follow-up on long-term basis, especially with chronic symptoms, look for any Barrett's metaplasia. What is the role of barium contrast study in children with suspected GERD? We don't do barium for the primary diagnosis of gastroesophageal reflux disease in children, but what is the use? As mentioned, we can only look for any upper GI anatomical defects like stenosis, any hiatus, any tracheostomy fistula, or any what you call it, malrotation, anastomotic strictures. So only just give the structural anatomy of the upper GI tract, not for the diagnosis. And motility disorders also. These are some of the examples. Just showing the image as a typical esophageal stenosis. And second one, achalasia cardia, dilated esophagus with a distal tapering, indicating a motility disorder, though we have the gold standard by the manometry, and hiatus hernia. Hiatus hernia are seen in children who are obese and overweight nowadays. And what is the role of scintigraphy? Scintigraphy, we all know that actually it indicates the gastric emptying time, but not routinely indicated, otherwise called as a milk scan. It has got low sensitivity, and in Indian children, we don't have any standard data, not recommended for diagnosis of GERD as a primary investigations. But in children, those are not responding to any PPI, they come with recurrent respiratory infections, aspiration, recurrent wheeze, and those are refractory or refractory GERD. We can subject these children to scintigraphy. And fourth case scenario is a 7-year-old boy with pain, epigastrium, heartburn, occasional vomiting, and nocturnal cough, and bronchodilators he was on for a lot, which gets aggravated at times. So this indicates that he has got a asthma, which is not responding. When to suspect GERD associated asthma? A typical symptoms of recurrent GERD in an asthmatic child, a typical GERD symptoms preceding exacerbation, or when he has got a nocturnal cough with wheeze and difficult to control asthma. But this is a controversial issue. Do all children with GERD are asthmatic or vice versa? What is the relationship between GERD and asthma? So this is always an issue, debatable issue. In GERD, the microaspiration of all the gastric contents, the acid, pepsin, bile, when enters respiratory tract by microaspiration causes bronchoconstriction, which is vaguely mediated spasm and going for asthma, are the drugs that are used for asthma that can cause relaxation of sphincter and can perpetuate the symptoms of GERD. So this is very, very difficult to answer. But subset, not all children with GERD, there is a definite relationship between asthma and GERD, even in India, but there are few patients who do not respond, but one who suspects the symptoms of GERD is going to aggravate the symptoms of asthma, then we can think. Otherwise, it's very, very difficult. We have to go for further investigations like impedance pH-metry in these children. And pH-metry, 24-hour pH-metry alone can just measure the frequency of acid eosinophil mucosa is exposed to at a pH less than 4. These we can just record for 24 hours. And we can, so now we have the gold standard, what is called as combined pH-metry with the impedance metry, which is now considered as gold standard. These are rarely used, but if it is available, it's a good test. Can be used in extra use of symptoms. Those are not responding to acid suppression therapy and to assess the efficacy of fundoplication. These are a few indications pH-metry can be done if it is available. And what is the role of drugs in GERD? The first line of drugs for GERD is always the proton pump inhibitor, and erosive esophagitis in all ages require empirical therapy, require PPA and as well as empirical therapy for typical symptoms of GERD. So it is always a PPA we have to give as a first line drug, both for erosive as well as in older children with typical symptoms as an empirical therapy. These we almost acts at the final is an inhibitor of your proton pump, a final common pathway of acid secretion. And since it requires acid in the parietal cell for activation, we have to give PPA just before food, that is half an hour before breakfast or whatever, once a day. We have a lot of PPA available in the market: omeprazole, lansoprazole, rabiprazole, pantoprazole, esomeprazole. All these are equally efficacious and they are very safe in children. The dose is starting from 0.7 to 1.4 to lansoprazole. Safe is 1 to 2 milligrams, just to remember. In practice, it can be given for from the ages of 1 month to 17 years. But in infants, empirical PPA therapy is generally not recommended as of now, unless it is proved by investigations. So as mentioned already, by 2 to 4 weeks, and those with complete resolution can be tapered 4 to 8 weeks. And extra symptoms role is questionable, especially those with asthma. Partial responders may require double doses. Those who require long-term PPA may require the lowest possible dose. And empirical therapy in infant is not recommended, as mentioned earlier. And what is the role of H2 receptor antagonist in children with GERD? H2 receptor can be used as a second-line drug, and those who the contraindication to PPA are when it is not available. But in India, all PPA are easily available. So only if there is any contraindication of PPA, I think we can go for H2 receptor antagonist. The receptor H2RA has got a rapid onset of action. So on-demand therapy, it is the best drug. Suppose for immediate relief of any heartburn, you can just give H2RA as a demand therapy. But the initial therapy should be always with a PPA. And long-term H2RA can result in phenomenon called tachyphylaxis, where they go for reduced efficacy because of subject to repeated exposure to the drug. Is PPA safe in children? PPA is safe in children. All formulations are equally effective. They are available as tablets, granules, and syrup. And adverse effects of PPA. Generally well tolerated in children and are safe. Long-term PPA can cause some GI infections, respiratory infections, and bone fractures, sometimes vitamin B12 deficiency, and sometimes a polyp, especially in old age. But in general, it is very safe. And for GERD, we are not going to use a long-term PPA like any other condition. What is the role of other drugs? Prokinetics. We all know prokinetics increases the gastric empty, it increases the LES pressure, LES tone, but not recommended routinely as of now. And baclofen has got side effects, though it has been used in adults. Precludes use because it causes dizziness. It reduces the seizure threshold in infants. So one has to be very, very careful. Not recommended as a drug for GERD as of now. Antacids, most of the antacids, they contain aluminum. So it can cause aluminum toxicity. And alginates can be used for children more than 12 years, but it has got a limited role. Sucralfate can be used, especially in older children, but not these are drugs not recommended as a routine, unlike PPA. So non-pharmacological, as mentioned earlier, feeding, whether the child has got overfeeding, then you have to advise whether you have to give a thickening of the feeds. So this issue, actually, thickening of the feed It's needed only in babies who are not breastfed, and thickening of the feed is very, is impossible practically very young infant, less than 4 months. But what are the things that can be added to milk? We don't have a commercial the formula that causes thickened formula as such, but we can add rice or cornstarch for increasing the consistency. But there's other issue. Too much of increasing consistency of the feed can cause diarrhea, sometimes delayed gastric emptying, which can even aggravate reflux. But we have to be very, cautious. So exclusive breastfeeding up to 6 months and continuing breastfeeding up to 2 years, along with complementary feeding, and after 1 year as usual, based on the custom of the family, is the best way to tackle GRD. Giving other formula is not advisable unless there is indication. Positioning, and I already mentioned, head and elevation and left hand position is very useful in children for GRD, especially older children, whereas young infant is always fine posture. Lifestyle changes in older children is very, essential. Weight reduction, avoidance of smoking and tobacco, especially when they're prone for that. We have to avoid all those things. Excess eating of junk food, because all this can cause reflux disease. What is the role of surgery? It's a last option, not for all. Those who have failed optimal therapy, especially those with neurological impairment and cerebral palsy, and those children with large hiatus may require surgery, hiatus with fundoplication. And these we have to tackle the feeding, especially neurological impairment is a thing where the child have multiple issues, including a nutritional problem. So how to give feed, whether to give nasogastric, which can itself increase GRD, whether to give a transplant feeding. So these are things we have to just address the issues, but they may rarely require, because putting the child on a peg itself can sometimes, we have to go distally. They have foregut dysmotility, they have oropharyngeal dysphagia. So especially children with cerebral palsy, we have to be very, careful in planning surgery. What best surgery we have to advise, we have to discuss with surgeons. And those with refractory GRD sometimes may get benefited with surgery, but not all. And those with acute life-threatening event, when they're not going to get all right, the drugs, the positioning, other maneuvers, whatever it is, may require surgery as a last option. So a simple algorithm, any child, infant is suspected GRD, we have to look for the child has got typical symptoms. Then if it is typical, go for lifestyle modification and empirical PPA, especially in older children. And we have to look for the improvement. If there is improvement, gradually have to taper. If there is no improvement, these children require referral to a specialist. Atypical symptoms, I think they may require further investigations, hence should be referred. Anyway, similarly, children with red flag signs should be tailored, whether the child has got a GI cause or a non-GI cause. Based on the signs and symptoms, they should be referred to the appropriate specialist. If there are no red flag signs and with typical symptoms, once again, PPA, if atypical, a referral to a specialist. So take home message, GERD is an age-related problem in infants, children, adolescents. A good history and physical examination is very, essential in all ages. And symptoms vary with the age and maybe esophageal, pulmonary, otolaryngal, even oral dental erosions. By and large, diagnosis very, clinical. But however, we may have to use some investigation judiciously in subset of children, because when they're not responding, going to respond to conventional PPA, other mode of lifestyle modifications. And empirical therapy is recommended when clinical diagnosis is strong by the primary caretaker. So thank you for the patient design.
Thank you, Dr. Sumathi. Can we have all the panelists on stage? And I think there are questions that have been asked. So let's get the first question to Dr. Riaz. Riaz, a role of H. pylori in chronic abdominal pain. Riaz.
Okay. You know that H. pylori is one of the most common infections in the world. Almost 50% of the world's population of 7 billion are infected by it. But the consensus opinion is that children with recurrent abdominal pain need not be subjected to evaluation of H. pylori because it's so common. But are there any specific indications for testing H. pylori? Yes. Suppose a child has got severe dyspeptic type of abdominal pain, he has got loss of weight, he's got nocturnal pain, he's got a stool local blood positive, that may be an indication. At the same time, suppose there is a child is on, there is a history of a peptic ulcer disease in the family, then one has to be careful. Or a child who is already on non-steroidal anti-inflammatory drugs. For example, you are diagnosing idiopathic dural arthritis and you are starting non-steroidal anti-inflammatory drugs. Then he has actually a dual risk of peptic ulcer disease. due to the drugs as well as the H. pylori. In such a situation, you should test stool for antigen. And if it is positive, you can start treatment. And you should make sure that it is negative also after treatment. Another indication is, suppose there is a history of gastric cancer in the family at an early age. You know that is one of the most common cancer-producing agents. It's classified as a carcinogen by the WHO. So suppose somebody has died in the child's family of gastric cancer at an early age. I suppose that may be an indication. Or a child with intractable iron deficiency anemia. Suppose you've got a child with intractable iron deficiency anemia. You're happy with the diagnosis, the ferritin is low, peripheral smear is suggested, and you start treatment, the child doesn't improve. Then studies have shown that H. pylori may be responsible, and that may be an indication for testing for H. pylori.
You will be very selective, Riaz. That means you are
that's it. Okay.
extremely rarely using.
These are very extremely rare, but sometimes.
One more question for you. What analgesic is preferred in chronic abdominal pain?
Okay. It's better to have analgesics like a mebeverine hydrochloride and rotavirine hydrochloride because they are smooth muscle relaxant. I think it's better to avoid drugs like cyclopamine, cyclopamine, which is the anticholinergic action and which may cause side effects including constipation. These drugs are now available.
One more question. Multiple people have asked. Ultrasound shows mesenteric lymphadenitis.
Okay.
When would you start crying over it?
Okay. Mesenteric lymph nodes, that is very common in children. It can be compared to the inguinal lymph nodes, which are common in children. Many of our children, most of our children have got some number of lymph nodes in the inguinal area. Okay. Similarly, whenever there is some sort of infection in the GAT, they tend to develop some nodes in the mesentery. So when you should be careful. Most of these lymph nodes, the site of lymph nodes is very significant. Suppose the lymph nodes are at atypical sites like the retroperitoneal area, the paraortic area, one has to be careful. But the size of lymph nodes, the more than 10 millimeter, one has to be careful. The echo texture is important. Suppose the radiologist says that it is of heterogeneous echo texture, maybe lymphoma tuberculosis. Look for a matting. Okay. Then you go by the symptoms of the patient. Suppose the child is very sick, you may require further investigation. Otherwise, just leave it alone.
Okay. Let's get to Dr. Malathi. You have a couple of questions. One is, what's the role of isotope scan, HIDA in NCS? You spoke very little about it.
I think HIDA scan was very tempting earlier because it was non-invasive and everyone felt it would give us a lot of helps in our diagnosis. But now it is very clear that it's only going to delay the diagnosis. So suppose the stool is chalky white, definitely don't send them for HIDA. If the stool is golden yellow, don't send because it's already going to be intrahepatic. Probably you will send HIDA if the stool is pale, if the baby is less than 6 weeks, then you have time, you may send because 3 days will take for priming. So that is why in the protocol, in ISPAGAN protocol, we have excluded HIDA. So don't delay sending this baby to the surgeon by doing HIDA. What you are seeing in the stool is what you are going to see in HIDA. If you see a white stool, non-pigmented, you will not see anything in the intestine. The thing you're not going to see. If you see a yellow stool, you will see the dye in the intestine. That is all. So radionuclide study is not taken, is not considered in the protocol.
A child has a total bilirubin of 15 and a direct of 5.
I think 20%, I think Dr. Rimjim wants that answer also. Total is 15. 5 is definitely more than 20%. So it is still take it as direct hyperbilirubinemia only. Because there's another definition. When the bilirubin is less than, total is less than 5, more than 1 itself is called direct hyperbilirubinemia. If the total is more than 5, more than 1.5 is called hyperbilirubinemia. That is another definition. So this you call it as direct, but you look for why is the indirect proportionately high. You realize whether there's some hemolytic component also, but this is still called as predominant direct hyperbilirubinemia, cholestatic.
Okay, one more question for you. CMV IgM is positive.
See, CMV IgM is a red herring, especially in India, 17 to 26 or even higher Mothers are CMV positive, so CMV IgM in the baby also may be positive. Just CMV IgM positivity, don't think that the baby has CMV and start treating it, giving Janciclovir for 3 weeks, 6 months, because it may be, the baby may have biliary atresia also. So unless you get a tissue diagnosis or you have urine CMV positive, or you show chorioretinitis or a microcephaly or a liver biopsy showing inclusion bodies, we have no right to name it as CMV hepatitis being the only cause. You must investigate further. But suppose you get CMV IgM positive, especially in a baby who we're going to do a transplant, then preemptive antivirals can be given. That's all. Otherwise, now the rule is don't give just for CMV IgM positivity.
Okay. This is a question to Sumathi. What PPI is best for young infants?
All PPI are equally efficacious in children. We can use either lansoprazole, even omeprazole, but omeprazole is available. Drug interactions are more common with omeprazole. I think esomeprazole, lansoprazole can be given. But all are equally efficacious in infant. There is no hard and fast rule which to choose.
One more question. How long should you give PPI for neurologically impaired children? Can you give it for very long?
So these are the children who require usually long-term PPI. Hence, there is a role, but we have to give at the lowest possible dose. But nutritional impairment is one thing. Just giving PPI alone is not going to address the issue. I think we have to tackle by going for other surgical options if available. Otherwise, only feeding and PPI at the lowest possible dose. But how long to give? There is no studies. But the maximum studies for 4.5 years in one study in children they have done where they analyze the adverse effect. But the options are many where they can go for other methods of improving the nutrition along with PPI we have to give. Once they come out, I think, but it's very difficult to come out of the problem because the primary problem is going to be there.
Can I ask you, Dr. John? There are many questions for you, but I'll ask you a few. I think Dr. Hari Kumar wants to know whether you could have chronic pancreatitis but no abdominal pain. You make a diagnosis of chronic pancreatitis, but the child does not have abdominal pain.
Yes. Even in acute pancreatitis, there are situations where it's not 100%. I think studies will tell you it's only 85 to 90% who have complain of significant pain. There are children who may just come with only vomiting. Chronic pancreatitis is notorious. You may not have pain at all. So pain is, if present, it's a good sign. If it's absent, it means that there is no chronic pancreatitis. Chronic pancreatitis is
there may be times when it's in remission also, no? Then you get an exacerbation, you may
get pain in between, but don't depend on only that.
In acute pancreatitis, someone has asked whether you can use Octride, doctor.
Theoretically, it's very good, but in practice, studies have found that it doesn't seem to benefit at all. So it's good, it gives pancreas rest, but in practice, none of the studies, even in adults, have shown that octreotide is beneficial. But
many doctors just prescribe this pancreatic enzyme replacement even after an attack of acute pancreatitis. Someone wants to know whether we have to prescribe after acute pancreatitis.
No. I think there is no indication to give pancreatic enzyme supplementation unless we think there is an exocrine pancreatic insufficiency. And that doesn't happen after one episode of acute pancreatitis. The child must merit pancreatic enzyme supplementation. It's not that it prevents, I find doctors putting them on thinking that if you enzyme supplement early, it prevents chronic pancreatitis or recurrent acute pancreatitis. No, it doesn't. Enzyme supplementation does not prevent recurrence of acute pancreatitis or the progression to chronic pancreatitis.
So in acute pancreatitis, do you believe in the rest theory? When do you start feeding? Do you use amylase as a surrogate marker? Someone wants to know.
Yeah, I said this earlier. I don't have any studies to back it up, but I usually go by the thirst and hunger of the patient. And usually by second or third day, they are fine. And you should be able to start at least the diet by second or third day. There is no advantage keeping children with pancreatitis nil-orally for 1 week and 2 weeks. We used to do that earlier. I think 20 years ago, severe pancreatitis were kept nil-orally for very, very long time. Today, nobody does that. You start enteral feeds early. Maybe you can give low fat in your diet, but they must be started on enteral feeds early. But if you have an acute severe pancreatitis, the issue is different, that you can't start feeding, then there is a problem. In which case, you could even go and give a short-term parenteral nutrition if you think you cannot feed them. But do not keep children nil by mouth for more than 3 or 4 days. This is not just for pancreatitis. I think for any disease. Nil orally is something that is very tempting for all doctors. You write their NPO and go away, and then it's repeat all. It's a wrong thing to do. From any illness, think twice before you keep a child nothing by mouth. Start feeds as early as possible. And if you cannot start oral feeds and the child needs to go nil orally more than 4 or 5 days for whatever indication, please consider parenteral nutrition. It is not very difficult. It's easy to do. Some
Yes,
other
sir.
one other question that came up for Riaz: role of probiotics in chronic abdominal pain.
Well, I'm actually not a big fan of probiotics, but there are some studies, several studies that show that probiotics may be useful in inflammatory bowel diseases, Crohn's disease, ulcerative colitis, pouchitis, etc., in pseudomembranous colitis. But what I feel, what I have seen many a time is that when I go as an examiner for undergraduate students, when I ask them, what is the treatment for acute diet disorder? Plan A, what is the treatment? I will be dismayed. I used to be dismayed when the students say that it is probiotic and Risicadot. The answer is that it is given in OPK. I'm sure that there is absolutely no role for probiotics in acute diarrhea, but in the other condition, it may be useful.
Okay, one more question for you. What is calprotectin? When do you do that? Does it help in chronic abdominal pain?
Well, calprotectin is actually a protein present in neutrophils. In inflammatory bowel disease, you know that a lot of neutrophils are released into the gut, and these are excreted in the stool. So you can quantitate the calprotectin in the stool, especially useful in inflammatory bowel disease, especially Crohn's disease and ulcerative colitis. If it is very high, to the tune of more than 500 microgram per gram of stool, it's almost definitely inflammatory bowel disease or Crohn's disease. 200 to 500 microgram may be suggestive, but if it is less than 50 microgram per gram, it is very unlikely to be a serious problem. Elevated level of calprotectin may help us to, it may be a surrogate marker.
It's useful to rule out inflammation of the intestinal tract,
That's
not
right.
functional disorders. In functional
That's
disorders, it's normal.
It will be absolutely.
Inflammation there is, but it's cruel to do a calprotectin for chronic abdominal pain. The cost is quite prohibitive. So
very expensive, useful, but very expensive.
So unless you have a strong reason to suggest that there is an inflammation, do not do a fecal calprotectin. Riaz, what's the duration of analgesic that you recommend in chronic abdominal pain?
Well,
chronic recurrent abdominal pain, how many days? Is it few days or do you give it longer?
Chronic abdominal, I try to use as few drugs as possible, just as William also mentioned. I just give an SOS dose of a smooth muscle relaxant like a Drotin suspension, which is available as a 10 milligram per 5 ml. I just give an SOS dose, maybe for 1 or 2 days. I do not use it on a long-term basis because it's a functional pain. There's no use.
Dr. Malathi, one question for you. You said up to 120 days. Beyond, suppose a baby comes at 120 plus days. Do you decide, no, I'm not going to do a Kasai, or would you still give the benefit of the doubt and do a Kasai, or it's an old controversy? Should you go for a
now I think everyone is recommending what is known as the late Kasai. Though the results may not be very good, we have to refer the baby if there is no ascites, that is, liver synthetic function should be good. There should not be any ascites and the prothrombin time should not be prolonged. Once you are sure like that, you can refer. Maybe the results may not be very good, but you have to refer up to 150 days with this time. But if there is free fluid in the abdomen or a prolonged prothrombin time, at 120 days itself, you should start telling the parent this baby may require a transplant. So though we say 45 days, 60 days, that does not mean you cannot refer the baby at 90 days, 92 days, 100 days. We've had babies with 120 days also with good results.
So days are only a rough guide. It's not a...
Yeah. Results are better when it's younger. And the synthetic function should be good.
Okay. To Sumathi, what's the role of sucralfate, Sumathi? You never mentioned anything about sucralfate.
Sucralfate actually it forms a mucosal protective barrier when given along with an acid. So it is a good agent. We can give for older children more than 12 years, not for young infant, but it can be given, but has got a limited role in treating GERD. Unlike alginates, I think sucralfate is better than drug.
Sucralfate is easier available and
It can be given.
probably there are more studies also to
Advise it.
Yeah. Riaz, one more question for you on rifaximin.
Well, rifaximin,
What
yeah.
are your indications for rifaximin?
The rifaximin is actually rifampicin, which is not at all absorbed. Almost 99% of